this for everyone too. So hope everyone's doing well. I heard you guys have a busy day with some group meetings for other classes. So I'll try to keep this brief. But this is our only group meeting for this entire class, and the only group work for this class. So hopefully that's a little of a plus on that side in terms of group work. So try to keep it minimal with this class. So wanted to say thank y'all for engaging in your standardized patient encounters and for coming today to the debrief. This, as usual, this is a confidential and safe space to talk and share about the encounters in the class so far. So our expectations are to discuss both cases. So we'll go over one and then we'll do the same thing and go over a second one. And then we'll just kind of wrap up with the rest of the semester questions if y'all have any. I'm going to be mostly facilitating, so prefer that you guys talk with each other. So I'll ask a broad question, but y'all can ask direct questions back to each other. So it's more of a discussion than a one-to-one debrief. So I'm not going to ask specific questions each time. So if you have questions relative to someone's answer or ask how they did that, please ask them and unmute yourself so you can do so. Just so you know, it lasts about an hour, so we should be done at 1. If you have extra questions, I'm free to stay on and answer those. And just remind you guys, the purpose of the SPs was to do an initial encounter relative to 2 specific cases. So first, let's do Keela's case or Michaela's case, and that was day 1, which was your dermatology one. So let's start there. So how do y'all think that SP went?
Very bad.
Agreed.
Worse than very bad.
I don't think that I went terribly, and this is not your fault. I need to be able to change my direction and not get so flustered. But like, I was going in there thinking it was Jessica with hip and glute pain, and then when she had a skin condition and her name wasn't Jessica, I just couldn't even think. Like, couldn't think.
Couldn't clear it from your mind, yeah.
No, and so then I was like, so I forgot everything that I wanted to say in the beginning of the patient encounter because I was like, okay,
what?
yeah,
Sure.
and like, okay, yeah, we had patient A and patient B, but like I should be able to change my way of thinking in a patient encounter because not everything is always as it seems. So yeah.
I think I just went into it with the mindset that, you know, you want to look at their history and like look at the patient that you're meeting, kind of like a physician walking into a patient's room. You want to know like who you're seeing and kind of a little bit of context. So I guess that's why I went in like, hi, are you Jessica? She's like, no.
And she had a preferred name, which I think some of y'all had touched on in your Qualtrics reflections I was just reading, that she prefers to go by Keela, but her name's actually Michaela, which I think threw off some people too. Like, that name wasn't on my list.
Yeah.
Yeah.
The only reason I wasn't like, hey, you're Jessica, right? Was because just from being in the clinic, we always ask, can you verify your name and date of birth? So that way I didn't have to make any assumptions. But then, even then, I had a hard time suspending reality in that moment because we have had SPs that haven't like gotten minor details right. So I was like, oh, well, maybe she just got the name wrong. And then I was like, oh, are you here for your hip? And I saw the skin infection, but I didn't want to bring it up because from that far away, you couldn't tell if it was real life or SP.
Sure.
That was kind of my first thought process. I saw her face, like it was very obvious, and I could tell she was kind of like covering it, but I didn't want to assume that that's what she was in here for. I didn't know if that was a part of it. So I did kind of the same thing and asked about her hip, and she was like, no. And I'm like, damn it. I should have phrased the question very differently. You know, what are you coming in here for? You know, something like very different than how I approach it. I also think I noticed a big difference just in personality from Keela to Jessica. Jessica was very like bubbly, welcoming, open, like willing to talk about, and Keela was very shut down. So that was a hard encounter for me because I felt like my questions were just a yes, no answer. And I really struggled extracting more information from her.
That was intentional.
Yeah, I figured.
Very good reflection, and I'm glad you picked up on that. I wrote that in several of your feedback to touch on that. specifically for, I'm going to use her preferred name, which was Keela. So for Keela's case, that was something that to touch on for sure.
I knew it right away. Like right when I started talking to her, I was like, oh, it's that kind of SP.
So how many of you on the Doxy app, specific to Keela's case, saw that her name was Keela in the waiting room? And you still called her Jessica?
I didn't.
I didn't
called her
call her-
Keela.
I don't even think I asked for her name.
Yeah.
I asked her to pronounce her name because I had no idea how I would have said it based on the spelling.
So in real life, this patient spells her name Michaela, Mikayla, like how it's spelled on the sheet. But she spells her name and prefers her name to be Keela in her real life. And I didn't know how to say her name either. And I was like, I don't know what to do. So we're just going to write Michaela down because that's what your birth certificate says. And she said, I prefer to go by this. I just go by this. And I was like, all right, well, cool. But I think it's important to check on the Doxy app because on the waiting room, you can kind of see who's in there too. So use kind of that resource there specific to the Doxy app that Double didn't necessarily have.
I was also logged in as Mr. Winkleman, so
Yes,
I
everyone
thought
was.
that maybe there's, she's logged in through somebody else. So
Yeah, that's what I thought
why
too.
I continued forward with Jessica.
Because Zach
Yeah,
is
so
the
the-
ISU.
Yeah, so the reason is because I have the account. So this was our account that we used with Methodist Sports Medicine to do our telemedicine encounters at Indiana State. And so this is my account that I own. So that's why it all says Mr. Winkleman on it because it's mine and it has it's connected back to my NPI number and everything like that. Otherwise, y'all all have to create your own accounts and pay money for that. So it's trying to save you guys some money, not have to spend that. So what were you or how were you feeling after Keela's case got done?
I felt like I needed to brush up on my gen med a lot.
Yeah, I was caught off guard by the skin condition, and then I just put my head on the table because I'm like, damn, I definitely got that one wrong.
I felt like since we're musculoskeletal professionals, like I felt like I did the right thing by assessing it and coming up with differentials and then saying, got to get you seen by somebody else who actually knows what they're doing, like someone who's going to be able to test it and give you medication, because medication is how you're going to treat, whether it's antibiotic or antiviral or whatever. That's how
Yeah, I think you bring up a great point there, Spencer. On your rubric, if y'all go back and look at the content checklist, you didn't have to get a diagnosis, but you had to provide a differential. And so it wasn't necessarily saying like, say this, but giving a patient some idea of this is what I spent my time doing, not you just talked to me for 15 minutes with no purpose. Because if you're going to say I talked to you for 15 minutes to refer you without providing some type of game plan or letting them know that you at least are a knowledgeable healthcare provider, that was kind of the intention of that area on the content. So if you didn't provide a specific diagnosis but provided a differential of things it could be, you got credit for that as well.
I thought, like, kind of going off of that, because I was talking to my husband afterwards. He's like, but you don't even do skin conditions. I was like, right. But really, if you think about it, no matter what we're looking at, we're really just giving a differential and then recommendations, even if it is musculoskeletal, because, like, that true diagnosis is only going to come from, like, imaging, really. And so the selective tissue tests give us a really good idea, but it's not actually, like, it's a clinical diagnosis, but it's not actually like a confirmed diagnosis. And we're just doing conservative care, which is essentially the exact same thing for the skin condition. It's conservative care with whatever, like, we thought they needed to do, whether like not play band instrument or water bottles or whatever, and then referring on based on that, which is what we would do with musculoskeletal. We would try conservative care. If that doesn't work, then you're going to refer on.
Julia, sorry, I didn't mean to call you Jenny. Julia brought up a good point there. How many of you feel that we don't treat skin conditions? Go ahead.
Well, if you think about like in a lot of, actually all the settings really, like someone comes to you with a skin condition, there's not much we can do other than either suspect that it's something that needs further evaluation or kind of do what Julia was saying. If it looks like I don't know, like a dermatitis or something like that, you might just be like, oh, put some antibiotic on it or something, or wait a couple.
It's really interesting though, because the NATA, I think what we guide most of our practice on as clinicians is our position statements, and there's a position statement on skin infections and acute skin trauma. So there's two related to dermatology specifically. So where do we draw that line of what's in our scope and what's outside of our scope?
Well, like I've done, like, in dealing with college football athletes, I've dealt with a lot of staph infections. So that is something I'm fairly comfortable with. Like staph infections, I've seen a couple cases of MRSA. I see a lot of allergic reactions and stuff like that, urticaria and stuff like that. But impetigo, I don't think I've ever seen. And there's quite a few on that list that I've ever seen. So there's a few that I'm quite comfortable with just based on the population that I work with, the fairly common skin conditions that I do see. And then there's others that, like impetigo, like don't remember that from the book exactly.
Well, I think it comes down to filtering those cases where we might be able to control the situation surrounding a skin condition. So in my factory, for example, I have people who get little mini hive breakouts from oil exposure because the oil is known to be a skin irritant. So we address that problem by rotating them, giving them resistant sleeves and hydrocortisone ointment, over-the-counter cream stuff, and then it resolves the problem. But if I identify a situation where they're leaking brown, yellow pus that's crusty, to me that says they need some medication or it's going to keep spreading or they're going to spread it to other people, and therefore it's qualified to be referred.
Yeah, Sam and Spencer, y'all got it right on the nail on the head there, and Julia's comment in the chat too. It's about the idea of recognition, I think, first, and making sure that you understand what is a communicable disease versus what is something that doesn't necessarily need immediate referral. And then after that process, intervening with someone, which was the point of the case, because this is a whole collaborative healthcare thing. And then after that, also, what is the role of yourself as a public health individual? So in terms of handling this condition in reducing risk or reducing long-term consequences of the skin condition, how do we help this person prevent this from getting worse, or prevent other people on the team or the marching band from getting this too? So I think that's kind of the clear role distinction here. You're not going to be prescribing medication, nor saying this is the medicine you need to go get. That's the role of your dermatologist or your gen med physician that you may be seeing. And so I definitely think y'all are on that right track there.
Well, sorry.
You can go.
So like last year in my clinical site, I had 11 out of 21 football players end up with impetigo. So when you look at the position statement, because I had to look it up, it says, I thought, like, what really comes back to this is that you can manage it, and as long as it's covered, students can participate. But like with Keela, if it's on her face, you can't necessarily cover that for her to be able to participate in sports activities. So I think that that's where you can kind of like make that, where it's important to know what you can and can't do, because like I can manage those who have it on their arm and cover it so that they can participate in football practice. But if it's on your face and I can't necessarily cover it, then it's just time for you to go and get treated.
Yes. We're going to come back to some specifics of impetigo because I want to touch on some like evidence-based medicine parts of that case specifically too, and then we'll do sciatica too, or the other case, which we'll touch on. It was sciatica. The cat's out of the bag. So for this case, what was the knowledge or skills that you think were needed to manage this SP?
I think recognition was big, and then I think patient education is huge, and that's just kind of going back to the topic we were just on, like what's our role? I think a lot of it is patient education, especially with skin conditions, whether it's a traumatic, like how do you clean a wound? A lot of people don't do it, like pour peroxide and alcohol on it, like seriously. And I think a lot of that is just patient education because people don't know. And like Keela, she came in, she's like, what is on my face? You know, I had these pimples and develop like this overnight, and I think it's our job to recognize it and educate them on what steps are next and what the prognosis is and what things they can do to improve their outcome.
Well, to tie off that, I think it's also a major skill that we as athletic trainers do, but I think we need to do better, is understanding the system in which we're placed. in order to deliver like a well thought out plan. So I just pretended, I suspended reality and I pretended that she was at my factory. And I told her, I was like, I'm going to contact the front desk person. You're going to have an appointment within the next couple of hours. But I think if you don't work or you don't understand that type of system, it's hard to be able to deliver that type of service to the patient.
I was going to say on that, in my clinical history, I have a lot of exposure with skin conditions because I worked a lot of wrestling. And if you didn't know as a provider, if you didn't know the process that the patient was going to have to go through when you saw impetigo, you were screwed. Like trying to convince their coach or their parent or them that they can't participate and here's why, you have to know that. So going off what Spencer said, like, yeah, you need to know the process of, is it contact? Is it not? Is it something that's spreadable? Is it not? Like you have to know those things. And I feel like kind of on the fly because, I mean, you can always go back and go, let me look it up. But at the same time, I think it's crucial for us to be able to recognize that.
For Keela's case, what was some key background information that y'all gathered?
Bandcamp, hot sweat.
I found mostly like her instrumentation, the psychosocial background of her case is what really helped me. And I saw in your comments, like I did not get off the idea that someone tampered with her instrument because I felt
so
like
Jordan, just to give reference to everyone else here, because I'm going to call you out right now because he brought it up. I wasn't going to. Jordan swore that someone at band camp played a prank on this girl, and he went back times. And I was like, bruh, it's not a prank.
I that's what was on my mind. I kept it professional, though.
You did. Yeah. Was that a previous experience that I don't know? Did you play? Were you in band? Okay.
No.
I didn't know if someone like played a prank on you one time and you like triggered.
Jordan's triggered on. He's like, I'm gonna get that person.
Okay, so outside at band camp, a lot of sweat. What else?
She mentioned that she, like a week and a half prior, she had really bad acne that had then resolved. And so in my mind, that was like open wounds susceptible for further infection.
So that's one good connection in terms of routes of the bacteria to infect someone. Anybody else touch on? I think very few people got into this with her. What else could have been a mechanism for this spread?
I asked about her sexual history.
Yeah.
I did that too.
I would say y'all need to go back and listen to your videos, specifically for both cases for people that tried to get into this area. I commend you on trying it, but go back and listen to how you approached it. My feedback may come off harsh, like just ask, but it wasn't meant that way. Like you beat around the bush of saying like, I'm going to ask you an uncomfortable question and you can, but I don't know how you're going to take it. So here comes the uncomfortable question. Like just ask the uncomfortable question. So, and especially if this is something that you are concerned about ruling out herpes or some other type of STI there. Good. So we got sexual history. What else?
So I have a quick question on that.
Sure.
Because I like when I go back and watch, I'm probably gonna like just cringe and hide under my coffee table for a few days. So like when I do that, do I just be like, hey, I'm gonna ask you this question? Just be a chicken?
Whose was that?
It's mine. I'm at my buddy's house. It was a rooster. Sorry.
Indiana props. Max, I would say if you can reach out to Julia or Sadie, they did this very well in their encounters, and I think not to say that I can't help you right now, but I think if they can help you or maybe share their video with you, and you can watch how they did those, they did it very well.
Okay, yeah.
So if you want to see how someone does it well, that would be a good one to go back and watch if they're comfortable with you doing that.
Okay, cool.
Okay, so sexual history, what else?
I was her skin hygiene, like how often she washes her face, and she was sitting there with her hand on her face. So I was like, just to caution you, like germs on your hand can make the germs on your face worse. So that was one thing that I asked her.
Yeah, a lot of people brought up skin cleanliness itself or irritants and allergens. regarding like lotions, changing sheets, if you had new foods introduced, etc. there in terms of what they've maybe been exposed to since band camp started, which I think was a very good route to go down as well.
I was a little bit disappointed that I didn't ask more about her previous history in terms of just illness. Like, what if she was dealing with some kind of, I don't know, some kind of systemic disease or something like that? And I didn't, again, it was hard. I felt like it was really hard to get answers out of her that weren't just one word. So as a clinician, I had a lot of trouble navigating how to ask those questions, because I almost felt like I was just pounding her with questions and I didn't really have a connection with her. So that was tough, I think, for me.
Yeah, because I tried to ask systemic, maybe potential infection issues, like, are you feeling feverish and all those types of things. I should have asked her, do you know what it is to feel feverish? Like, I should have, because I was like, do you feel feverish? And she's like, no. And I'm like, okay, cool. And
So,
then,
Kendall, I think you bring up a really good point there. If y'all go back to that content checklist specific to Keela's case, it has a list of things to ask there during a gen med evaluation that should become common nature. So I know some of y'all like the checklist approach to going over some history questions. If you go through there and look under the gen med part, there's one that asks about like pain, stress, coughing. All those should guide you in terms of history taking for gen med conditions, to guide you in terms of, is this vector-borne, is this a bacteria, is this a fungal, and should help to guide you through that type of questioning a little bit better. So I appreciate the ones that asked about some of those type of things, but also exploring how this systemically may be presented. So are they having abdominal pain? Are they having pain with bladder or bowel movement? Things like that. One other thing that I don't think most people touched on was the use of her instrument. And so I want to share my screen really quick with you guys. So in case no one has participated in band before, can y'all see my screen?
Yep.
So this is a trumpet player. So if you can see on her face where the mouthpiece would have been, see?
Mm-hmm.
So mouthpiece hygiene has a strong link back to, stop sharing the screen. Strong link back to Staphylococcus aureus, which is the origin of impetigo. There's actually about 2 or 3 different studies out there linking back how people that don't clean their woodwind and brass instruments well, so people use reeds or mouthpieces, have a higher likelihood to develop some type of staph infection, including MRSA or impetigo. And so asking people about their instrument hygiene. So Keela's case, if you got into it with her, she would leave her instrument down in the gym or on the floors and not pick it up and not clean it because we're there all day. And so this is how the transmission of the disease actually happened for her. This is actually based off a real case that I dealt with when I worked basketball. So I had a basketball player. The same literature is defined there with using reusable mouthpieces, so like the clear ones for your teeth. So he used to keep it in his sock during practice when he was out of drills, and then take it out of his sock and put it back into his mouth, and then put it back into his sock, and just went through that process. He had very low health literacy in terms of, sweat, bacteria, this could make you sick, and he'd be like, have the mouthpiece like hang out of his mouth while he was standing there like talking to coaches and stuff. And so the bacteria from his sock got on the mouthpiece, spread on his mouth, got impetigo, diagnosed with it, and had to go through the whole 9 yards. So considering other aspects of things that may be touching their mouth rather than just sexual partners or new foods that may be introduced as well.
I was like, did you share your trumpet? Did somebody play with it? And she goes, no. And I said, good, don't do that.
Yeah, I think a lot of people ask, are you sharing your instrument? And in reality, band members don't share their instruments. Like a trumpet costs about $800. So you have to realize like that's their property, and that's something that they're going to be sharing. It's like a baseball player. Like, I'm not going to share my bat and my glove. Like, that's my stuff. It's the same thing in band. So translating some of that stuff about sport equipment over to band and marching band and things like that may be helpful when you're exploring other emerging populations too. How did you feel about the difference in the telemedicine platform, and what would you have done differently if you were face-to-face with this patient?
If I was face-to-face with her, I probably would have actually gotten hands-on the skin condition, obviously with gloves. But I think that can say a lot about what it is too. So that would have been something a little different if I was hands-on.
I think maybe for me, the only thing I would have done different in person was taking vitals, just to cover that base, because I've made mistakes related to not taking vitals in the past. So I try to do that at least for all gen med cases.
I also wonder if her kind of personality would have been different versus
Yeah.
in front of a computer screen versus in person. It's kind of more personable, so she might be more open about stuff.
It was hard, the eye contact. Like, I've been practicing looking at the camera instead of looking at my screen, but it's still difficult and she had a hat on too. So it was even harder to see her face, and she was like covered. So I just felt like
so she should have been sitting like this with a hat on. So this is what you probably got. Yeah. Anything else? What y'all think about the Doxy platform itself?
It's pretty smooth.
It's like using Zoom, right?
Yeah.
Mm-hmm.
If you pay for the additional features with it, you can take screenshots. So something that I think some people mimicked or pretended they did was to take a screenshot of the patient. That would help with the dermatology reference. And so if you are going to go and consult with someone after, especially for dermatology, they probably want to see what it looks like expressed 24 hours after, because they're not going to be seeing them at that point. And so you have to consider progression of the disease. So like if you have a tick bite or staph infection, a lot of people like draw a circle around it to see if it's growing or getting bigger. The same thing could be true of using pictures through telemedicine. So taking a screenshot through the system and then being able to track it over time if you're going back for visits, or sending that to the dermatologist for a reference as well.
Is the Doxy platform free? And then if you want the professional version, it's whatever, $30?
Yeah, so you use the free version. We used to have the full upgraded version where you can do a 3-way call, screen share, send files back and forth. That costs $35 a month, or it's $350 for the full year, so they give you a little discount. And that allows all the systems to be in there, so you can bill through it and everything like that as well. But the system y'all used was the free one. So just to touch on some other impetigo things, just to wrap up for this case and move on to the next. So impetigo is a bacterial infection. It is highly contagious, and it can come in two forms, so a bullous or a non-bullous. So a bullous one is the one we don't typically see. Those are the ones that express on people's arms, their stomach, their legs, and this is usually a more rare condition compared to the other type, which is the non-bullous, which is the one we see on the face and below their nose and around their mouth. So it usually is contained right around that area. And it usually starts off as really thin little walls that rupture. And then after they rupture, they leak out a yellow fluid, and then the yellow fluid crust over, and that turns a darker yellow or brown color. And that's why you get that honey crusted condition around the outside of it. So in Keela's case, there were some that were still red because she expressed that this only started occurring over the past 24 hours. So those were those new non-bullous formations on her face, versus the one below her nose and right out the corner of her mouth, which were darker and yellow, that she had said that popped last night while she was sleeping and some yellow fluid leaked out. Those are ones going through that stage of becoming that honey crusted area. And so that usually exposes and happens pretty fast. That crusting happens. But even if they've popped or leaked out or desquaminated, if you will, the material out, that doesn't mean that she's now healthy. That just means that it's expressing how it's supposed to express, which means it's going to continue to spread across this person's face. So history, our diagnosis of this condition is primarily done by history taking and appearance of the lesions. And so while most of you referred on, typically this condition can be diagnosed by those two things. If their lesions are not, I guess, performing well, or they're continuing to spread, that's typically when a culture is done. So just a dermatologist most likely will go through a visual characterization of the lesions and prescribe a topical or oral antibiotic almost immediately without doing a culture of that, because just of how it expresses. The literature states that topical cream for impetigo, especially on the face, is the best option to go due to side effects, but you can do topical or oral, or a combination of both, depending on how long or how fast you want it to go away. But the criteria for this specific to athletic training is that no new skin lesions for 48 hours. So if someone has impetigo, they can't have a new lesion pop up within 48 hours. And they have to complete 72 hours of directed antibiotics. So that either that's topical or oral. So after that, then they can return to play. So considering what that is now, how do you think your patient education in terms of going back to band camp fit in for Akila's case?
Not good. I told her to go back and just cover it all. So not good.
I maybe would have spent, knowing that 72 hours is the time, I probably would have tried to mentally prepare her for needing Monday, Tuesday, maybe Wednesday off before returning, assuming, or whatever day of the week it was,
Sure.
before returning following that referral.
Good.
Also, would it really matter, because she's not in contact with another person? Would it really matter if she has an open lesion and is still playing? If
So,
it's being treated?
Yeah, so the way the position statement's written is it's returning it to competition. So competition assumes that they are competing or doing something, but that doesn't necessarily, they don't define competition as individual or team-based sport in the position statement. So anytime you're returning back to activity that you're doing. For this case, I would caution on the side of I think Julia gave probably the best recommendations in terms of what to do next. So I would suggest not going back to actually playing their instrument. But Julia, do you want to share some of the things that you suggested Keela to do?
Yeah, so I didn't want her playing her instrument because I had no clue what it was, but I just felt like anything touching the skin was going to make it worse, regardless of what it was. And then also there's open sores, so any germs could get in there and start a new infection. So with that, I just told her, don't play the instrument, don't share water bottles, have your own. But then with that, you could still, if it was marching band, which you said it was, you could still march, you could still read the music, you could still practice that and memorize your sheet music and practice the routine, but you just can't have the actual instrument to your mouth.
So those are some good recommendations to involve the person still in the sport. Also addresses the embarrassment and mental health side of the condition, the psychosocial, especially regarding how the person may feel isolated if they're missing band camp for this patient as well. What other questions, concerns with this case? All right, so we'll move on to Jessica. So Jessica, how do y'all think this SP went, and how did you feel after this one?
Much easier.
I definitely felt a lot more fluent with it. I think, again, part of that was her personality was a little bit easier to talk to, but I did not do a good job with presenting her with potential options. I kind of got to the point where I ran out of time because I asked her about her any changes in bowel, bladder, or menses, and she said she had quite a bit of pain with difficult bowel movements. So then my mind started going, crap, like now we have a whole nother literally potential list of things. So when that happened, at first I was a little bit confident of what it potentially could be, and then that happened, and I had her kind of poke around and show me where she was tender, and she wasn't tender anywhere on her actual glutes. So that threw me off too. So I think in the end, I never really gave her an answer. And I even said that, I'm like, I don't have an answer for you. I don't really have a good response for you. This is something we would need to spend another session digging into. I have a lot of good content, and I think I have a good direction of where we need to go, but I don't have a response for you now. So that part for me at the end was a little more challenging.
Sure.
I agree. I kind of gave her the same, it sounds like the exact same thing. I was like, this is either hamstring, piriformis, or pelvic floor, which are all off the wall kind of different things, but with where the pain was and then those additional symptoms, it kind of threw me off too.
Yeah, at the end of it, I was like, great, you have sciatica, but not sure where that, why that's happening. So I need to see you face to face so that we can figure out why you're having sciatica.
I think you did really well with that, Kendall. And Julia and Sadie, I'm going to come back and touch on those findings because you're the only two I think that I found those. And that's why I told Max, go back to listen how people do that. So I think you were the only two that asked those questions, and the case was designed for those to be there, but it's based off evidence. And so I'm going to come back and touch on that, why those things were presented with this case for you. Kendall did a really good job with defining a diagnosis, but not the root cause of the diagnosis, because we know sciatica typically has a root cause. Sometimes it can be spondyes, it can be a disc herniation, it can be piriformis syndrome. So typically we have sciatica with another root cause or a root condition coming down there too. So good job there. What were your favorite and least favorite aspects of this SP?
The patient was so close to the double. And so like when I—
Was that good or bad?
No, it was bad because I was so nervous that when I like took it out of the thing that I was just going to run into her. And like we weren't able to practice moving the thing around, so I didn't know how like fast it was going to move, like how when you press like move forward just once, like how far does that mean it's going to go? And
Sure.
so that was the most difficult part for me, was that little thing.
I think on that one, on the double, I even like asked the patient to move back instead of me moving the actual double that could move. So it was just one of those things, like understanding how to
Someone
move.
asked her to keep moving forward too. So other people were saying, keep closer to the screen too.
Yeah, I completely forgot I was using the double. I don't know why I blanked, but I was in the mindset of using Doxy, I guess. So I didn't even think about using the double to be honest with you, because I just don't know why.
Yeah, I think Louis, I think you were about the only person that actually drove around. Can you share your experience driving?
It actually wasn't that hard. I was worried that whenever I touched a button, it was really just going to go off the rails, but it really doesn't. Like as soon as you stop touching the button, it stops. And then yeah, so like I took it forward and then turned it so I could see her from the side view, and it actually worked out really well. And I made sure, kind of like Kendall was saying, to be like, I'm about to move this. I'm not a very good driver, so watch out. And then kind of went around. But yeah, it was actually really.
But I took a picture of what he was doing. So this was Louis. So he moved the robot and had the patient use the table for his exam.
Oh, that was smart.
Very smart.
Pretty good, Louis.
Yeah, except for I ran out of time and didn't get anywhere near a diagnosis.
Hey, that's practical.
I think I was too worried about getting the diagnosis in mind, and I think that's why like all the telemedicine stuff I totally missed on both of them, and I think it's because I was too worried about the actual patient in it.
Kendall, can you tell me, I forgot what I wrote in your feedback. I don't know. Did you read it yet?
No.
That's fine. I think Kendall did her second encounter with Jessica. She did every telemedicine aspect, and I think it was 1.5 minutes of the actual encounter. So she went through all parts of the telemedicine prep within 1.5 minutes. And so I think a lot of you had expressed in the discussion board and in some of the reflections and just talking or hearing from some of you that I don't know how I'm gonna get this all done. Like, how am I gonna do this plus an encounter? And it's really not that much more. It's simple questions. Device plugged in. Can you hear me? Can you see me? Do you know what's gonna happen? Do you have consent? Let me show you my room and move on. It's pretty quick things unless people have questions or they don't know what to do, which is when you run into the issues of saying you gotta slow it down so they know what buttons to click or how to navigate the system.
So where I struggled with in terms of like time management, I guess, was the idea of utilizing a PRO. Like I had ortho scores pulled up and everything, and I just never had a time or a chance where I was like, this is a good time to share my screen and let them fill something out. Or
I was going to ask that same question, and this is relating to Keela or Jessica. I felt like I did the pain rating scale, and that was it. Like I agree with Spencer. I didn't know where to plug that in or how to do that with the time and just where in the evaluation.
Which was interesting because when y'all did the pre-encounter on lesson 4, several of you tried to use a PRO during that time, and that was a 15-minute encounter as well.
I still don't get where that would have fit during that either.
Mm-hmm. I definitely struggle with that too. The one I try to incorporate is the patient specific functional scale. So asking them like, if you're able to, or think of something you're not able to do right now and you want to be able to do, scale that. But Other than that, I'm really struggling to find what PROs would be able to be incorporated.
Sure.
And my other thing with the PROs is like, do I send it to them with like telemedicine, have them fill it out, or do I like talk through it with them and kind of have it? Because like if I talk through it, then that takes time, obviously if we're on a time limit. But like if I can send it to them, then I can like be looking over my notes when they're doing that or something along those lines.
Yeah. So from my experience, when I've used it, is so like on the doubles, I pull it up and I say, so I go 1 and then ask them where they're at. So I go through with them and I document it, because unless you have a system that allows them to actually touch and complete it, you're just doing a screen share. And so they can't actually, so like on Zoom, you can share the control and someone can control your own screen. And so that would be possible for them to fill it out on your screen for you, and then it's on your computer. But on Doxy or the doubles, it's just a screen share option. So what I've done is it's to go like 1, so if I pull up the quick dash, like pain with overhead motion, do you have pain putting up your groceries, getting your milk? And so I'm asking the questions, and it's like, yes, no, above average, below average, things like that. And so they're telling me, and I'm just checking it off on a system really quick. So incorporating that into your history portion, specific to the functional limitations they may have, may be the best place to incorporate it. But you got to find one of those quick PROs to incorporate there. I would say no more than a 10, 12 question one, because it gets monotonous, if you will, to ask a question and then repeat it back and forth like that for you.
Question. So say we were like in that sort of a clinic, like the virtual clinic, would it be possible to do like a patient history questionnaire and the PROs with that way, like, and have them sent electronically to the patient and then filled out in that way?
Yeah. So one of my assignments I have for the Gen Med class that I'm teaching at South Carolina that I've made is a PPE form. And essentially they're doing an entire PPE form. And then when they get on the telemedicine call, they'll go through the form with someone and ask them questions about it. So if you're creating a form like that, or a patient intake form, or some type of form like that regarding if they, for this example, like Jessica went in there and said, I'm having glute pain, you could pull a PRO like the less, have that sent to them, and then get on and say, like, I'd like to talk to you about some of these things, which may be a great way to incorporate that in the future. All right, so what were some key things y'all were able to discern from Jessica's case?
She sits for 10 hours a day, at least 4 days a week, driving, a lot of sitting. Previous history of back injury.
Okay.
Neuromuscular and vascular issues with that prolonged sitting.
Okay.
How did you determine the vascular part? I didn't get that.
She told me it got cold when she sat for a long period of time.
What else?
She had to change her routes for driving because she couldn't do the long distance ones, or she made a comment about being able to do long distance ones, like you with having this resolved.
Yep. Anything else?
We talked about before, she had complaints of increased or the same pain, increased pain with difficult bowel function. She mentioned sleeping on her stomach was the most comfortable, or laying on her stomach was the most comfortable, but that she had disrupted sleep.
Very good. So at that point, what was y'all's mind thinking in terms of a differential when you got going?
Sciatica caused by something.
Did anybody consider other outside diagnoses?
I was really thinking something discogenic or something in the lumbar spine because of her previous history there, and especially with the positive Valsalva, really, if you're having a difficulty bowel movement.
I think going off of Sadie's of her sleeping on her stomach, I think I was thinking like low back too, because a lot of people do that for low back pain.
Or SI even.
Yeah.
Yeah, I tried to really focus on the SI issues because she wasn't able to tell me what her back injury was in high school because they never really told her what it was. And so I even specifically stood up and asked her if she was having SI pain, and she wasn't. So, because I really focused on that.
I was thinking more like pelvic floor issues because of where she
I
said,
loved that train of thought you had, Julia.
and then also she had increased pain with, like during her cycle, she had extreme amounts of pain, and so I was thinking more like pelvic floor dysfunction of some sort.
I didn't even have that on the case differential when I made the case, and I added it after you said that because I think the way she presented definitely should have put some people down that route. So really good job connecting that. And connecting back to Dr. Park's presentation from DAT weekend last time.
I think that's what threw me off the most is after I asked that question, I'm like, well, shit. Now we have a whole nother slew of things that could potentially be, you know?
Yep. So when you got into your data gathering portion or your evaluation, what were some things you did and what were some limitations of the telemedicine and what were some benefits?
I felt really limited because there wasn't an exam table and I didn't think to put her on the table that she was right next to because I wasn't sure how sturdy it was. And then also, like, in a telemedicine encounter, you may not have somebody who has access to, like, they might be in their living room, and I guess a couch could work, but a little different. So I struggled with that.
Because I was thinking about putting her on the floor too, but then I like tried to lower double. And then I was like, oh, it's at the lowest point. So then I was like, this wouldn't really kind of like get to that level of being low enough.
I tried to get her to do some more maybe functional movement in her chair, like do a figure 4. But that didn't bother her at all. So that's why at first I was like, okay, I'm thinking sciatica. And then she did that figure 4 and even palpation to the glutes, no pain. I'm like, that doesn't add up. And then on top of that, the pelvic floor stuff, I was like, ah, crap.
Well, and that was my thing because obviously, like right at the beginning when she was talking, I was thinking piriformis syndrome because she sits so long, and then she didn't have any pain with her figure 4, and you could tell that she had been trained as an SP to like really make sure to mention she didn't have pain with a figure 4, and I was like, well then, and then with the not being able to tell me what her back issue was in high school, just that's why at the end I was like, well, you have sciatica, but we need to figure out why.
Spencer, can you touch on some things that you did or asked her to do?
Yeah. What did I do? So I started out with like a basic like ergonomic question set of stuff. I asked her about like how old the chair was that she was sitting in, if she had any like extra, lumbar support or anything like that. And then I moved into doing, it was hard because I didn't think about putting her on the table. I kept her in the chair, but I did things trying to provoke different muscular systems and where they would put tension on the sciatic nerve. So I had her basically do essentially a slump test, and I broke it down to kind of get that hamstring involved. And that was like my primary, like, yeah, there we go. We got something because I did the figure 4, and I also had her like really like raise. I had her in a figure 4 position, and then I had her raise her foot off the ground to like really exacerbate that piriformis, and it didn't do anything.
Yeah, I think Julia, Ansley, and Spencer all did a slump test, which was really nice to see. I think Julia did a really good job breaking it down to actually put them in that position. So really good job with that. With the figure 4, the favor test that you were basically doing, it's not necessarily sensitive or specific to sciatica. Its highest specificity is for SI joint, and so being mindful that even if someone has sciatica, putting them in a figure 4 doesn't necessarily mean they're going to have pain. So we'll get into some of the special tests that would be more beneficial related to sciatica. But what I'm trying to touch on and why I'm calling out some people is that Sadie and Julia did a really good job with asking about bile, bladder, menstrual, and sexual activity. Spencer asked really good questions about ergonomics. You have to realize these are your kind of niches in the program. You got to work from each other as a cohort to say, how do you do this? You do this every day. Spencer asked the question, how do you sit in your chair? I never would have asked that question, but it was one of the best questions. Like, what do you actually look like when you drive your truck? And I never would have thought about that, but Spencer works with this type of patient every day. So trying to work and play off each other's strengths in these type of situations, especially after you debrief to hear what people did to guide your practice, I think would be very beneficial. So kind of get into some of the background on sciatica. So risk factors for sciatica, is age, so 45 to 64. This patient was 23, so not in that age range there. Increased risk if they're taller, and increased risk if they're a smoker. No one asked about smoking. She was a vapor, and so she used e-cigs regularly for the past 5 years. So asking about smoking would have been helpful. And then mental stress. Some of you touched on it in terms of how do you feel, and she expressed some social stress in terms of not being able to engage with her friends because she's been absent because her pain starts. So understanding that a mental stress can exacerbate the sciatica symptoms as well. Occupationally, frequent lifting, bending, twisting, and then driving with whole body vibration, aka FedEx, UPS trucks, Postal Service, things like that, are the most common factors that exacerbate sciatica symptoms occupationally. And so when you're exploring emerging settings like this too, understanding that someone's driving, that's going to be a trigger. And then pain that's worsened with some other symptoms. So as Julia and Sadie touched on, so if during their menstrual cycle, or if they have a difficult bowel movement, the pain may be exacerbated. Specifically during your menstrual cycle, the endometrial tissues swell and press on the sciatic nerve, and so it's not actually a menstrual issue, but it's the swelling during the menstrual cycle that presses on the sciatic nerve. So if someone has sciatica, you should acknowledge or educate the patient that during your menstrual cycle, you may see a flare-up in the first 2 to 3 days when the menstrual cycle starts. And then other things that will cause issues: sneezing, coughing, laughing, hard bowel movements. So anything where you're having to put pressure may cause the sciatic, basically a Valsalva, is going to cause the sciatic nerve to exacerbate that pain too. What is something else? She does need a squatty potty. What is something else that would be a trigger that you may have seen in everyday life? So Sam, Louie, Jordan, Max, Thomas, Spencer. I'm gonna stereotype you. Do you wear your wallet in your back pocket?
Mm-hmm.
No.
No, actually, I don't.
I don't either. Mine's on my phone.
All right, well, I do, so you can stereotype me.
Okay, so me and Tom are the only one.
Yeah, so I used to all the time, and then my whole spine got messed up because sitting on a wallet, especially if it's a thicker one, can exacerbate the sciatic nerve pain. So asking about those things, don't gender discriminate in terms of asking Jessica if she wears her wallet or carries something in her back pocket too. But knowing that if somebody's carrying something in their back pocket, especially on the side that they're having the unilateral pain, that's a quick thing to change immediately to make cell phones, making sure they make that quick change to see if that alleviates symptoms specifically. So how we've kind of adapted to our lives in carrying things around. So ironically, this case is mainly diagnosed by history taking as well. So I picked cases that you could have hopefully diagnosed through the history taking, because I know the limitations of the telemedicine. So some of the key factors are radiating pain down the leg specific to the nerve distribution. And then unilateral pain that is greater than low back pain. So when you're trying to figure out, is this a sciatic nerve issue or if this is radiculopathy or some type of disc herniation, the main thing is to ask, if you have low back pain and you're having this radiating pain, which one's worse? If they're having worsening symptoms in the radiating pain, it's typically sciatica. If they're having worse pain at the low back, but they're also having radiating pain, it's typically low back as the root cause. Another thing to differentiate between piriformis versus sciatica is to ask if they're having muscle weakness down the leg or above and below the leg. So typically with piriformis, they'll have muscle weaknesses or imbalances above and below, versus sciatica, it's typically just below. So understanding kind of that region and how that will guide your questioning or your diagnosis.
So for that, would you just say, like, do you feel weaker with knee extension, or when you go up and down? Like, would you just use movements essentially that are going to be those muscle groups, because they're not going to know, like, I'm hamstring weakness?
Yeah, I totally understand with telemedicine, it's a limitation. I think it's hard to do any of the resistive range of motions, even passive range of motions. Like active, you can definitely do. But getting some of those good manual muscle tests or resistive range of motion is a definitely limitation. That was more just me throwing that out there for in case you see this in your clinical practice rather than more the telemedicine part. Sorry, I should have clarified that. But asking them if they feel like a weakness, typically a patient will know if they're feeling a weakness in their limbs or their low back.
That was something that I put in my reflection, like my Coltrix thing, was that patients have lived in their body their entire life, so they're able to recognize differences, and I don't necessarily have to put my hands on them, because that's my biggest issue with telemedicine is like when I go into a patient encounter in my clinic, like the first thing that I do is I want to like touch them and put my hands on them, but I just need to sit down and ask them questions because we were able to figure out both of these things without actually touching the patient.
Isn't that crazy?
And so they are able to tell you like, well, yeah, because I even asked my patient, like, do you feel like your left hip is lower than your right hip? Because when you put your hands on your hips, you are able to tell that as a person. So I think that that's one of the biggest things with telemedicine is like you can ask a person.
Yeah, like Kendall, you checked hip alignment, you checked leg length discrepancy, all things that if you have someone visually inspect and you're guiding them through questioning is possible to be done. It's just having to be creative with it. In terms of a couple other things that I want to touch on before we run out of time. So the person had numbness and tingling. Consider how you can actually assess this. So I wrote it on a lot of your feedback, not just ask, do you have numbness or tingling, but getting some quantifiable information. So like Jordan got more information about it being cold, asking where that distribution is located. I think some people had her demonstrate where she felt the pins and needles or the cold sensation specifically on her leg to kind of understand that. But understand you can also do like a 2-point discrimination. Can you feel these areas? Do some dermatome testing. Actually understand, is this actually a long-term neurological issue or is it a short-term neurological issue, and get some information there. In terms of special tests, I think I only saw 1 or 2 people do it, but the best test for sciatica is the straight leg raise test. So it has a 91% sensitivity, so it's really good to rule out stuff. Has a low specificity, it's about 20%. So it's not the best test to rule in something, but typically there's a straight leg raise, and then you have some modifiers to it. So you can have them dorsiflex their ankle, you can have them bend their neck down. Those will tell you a little bit more about the pathology. Straight leg raise test is also called Lezage sign. It's spelled all French-like. There's apostrophes and stuff on it. It's in your rubric if you want to go back and look it up. Essentially, the main thing there, what you're asking to do is someone laid on a table and you ask them to do a straight leg raise. In that 35 to 70 degree range, do they have pain? If it's past 70, it's SI. If it's below it, it's typically not anything. So if it's past that 70 degrees, that's when you're going to get the SI joint moving. If it's in that 35 to 70, that's when you're thinking more of a sciatica, specifically for the straight leg raise test. So it's an easy test, the best one in the literature to support it for sciatica specifically.
So you're saying if it's under 70 degrees, it's likely sciatica. If it's over, then it's SI? SI.
So if we're here, if they're under this range, they typically won't have pain at all. If they have pain from 35 to 70, that's sciatica. If it's 70 to above, and that's when the pain exasperates, that's typically an SI point. Disc, yes. Good. All right, questions on the presentation of, or this case specifically? All right, so most of the other questions that I wanted you to ask, I think, are in the reflection questions. The main thing I want you to think about is how much your comfort changed that I was able to see between the 2 encounters. To me, it showed that this is something that's uncomfortable the first time you do it, but if you try again, you probably can incorporate it a little bit better. So it's just like doing all of your exams and how you learn to be a clinician. Just take some time and practice in refining what you do. So what are some of those skills or attitudes that you think would be useful that you gained from this experience, and how do you think you can move forward with it?
Can you ask that again? I couldn't hear you.
What are some skills or attitudes that you were able to gain from this experience, and how can you move forward into your clinical practice with it?
Definitely sit down and talk with the patient first. We talk about it all the time, and we even did it last DAT weekend, that we are really bad at listening and doing something at the same time. So just sit down in my chair, have the patient sit on the exam table and talk to them first. instead of automatically going in and starting moving them around and all that kind of stuff, because I don't think I'm able to focus on my selective tissue test and what they're telling me at the same time.
Good. Anybody have a reflection about the time limit?
I was going to say, I think that this was a good eye-opener that even if you have a shorter amount of time, there's still a lot you can get accomplished in that time and how to be efficient with it. So we only had 15 minutes and we had to get a few differentials for the patient done. Did you do that or not? If you didn't, then I didn't. I took 18 minutes, I think, and I still never even I never presented the patient with options. I was just like, we need to look at this a little bit more in depth, but I think that goes to show that it can be done in 15 minutes and it's good practice.
And I want to reiterate, I'm not trying to say you need to do telemedicine encounters in 15 minutes or you need to do your encounter in 15 minutes. The reason was that to be mindful of that you all have jobs and lives, and I was trying to get 2 experiences in, because when I did this for my dissertation, I realized that 1 experience isn't enough. And I wanted to see if if it changed on the second time. Once someone does this, does it actually just help them? And from U12, it demonstrated that it did. You just have to give someone another opportunity to do it before they feel comfortable. And I think that's something you can translate into working with new employees, if you have students, different things like that. If they screw up the first time, doesn't mean they're bad. Give them another chance at it to see if they can correct their issue or their struggles that they had.
The biggest time constraint thing that I had, which it was 1.5 minutes, I looked at your feedback, was the whole, because when I walk into a clinic with a patient encounter now, at my current clinic, I don't have to do all of that stuff. So I was so nervous that was going to take up so much of my time to try to explain to them what we're doing, like why we're using it, consent, and all that kind of stuff. When I can just currently walk into my clinic and I'd be like, is it okay if I touch you? And they're like, yep. And then that's it. So I was so nervous that was going to take up so much of my 15 minutes, but it really doesn't. So that's why I was concerned about the time constraint.
Good. All right. If no one else has any other reflections, I'm going to go ahead and end this. If you want to stay on and ask questions about the rest of the class, I'd be happy to. I'm just going to stop the recording, but then I can answer any questions related to the final long-term assignment that you guys have. So please don't forget to get on to Blackboard and do your collab quiz. So it's 1 question saying you showed up today, and you'll get your 5% for that. And then your reflections are due by the 23rd. And then the last assignment's due on the last day of class, which is August 2nd. So you have the rest of the class to do it. You have no other material delivered. There's nothing else. It's just working on that assignment for the whole rest of the time. Cool. All right. I'm going to stop the recording. If you have